Good morning, everyone. Thanks for joining us. I want to welcome everybody back to our Treat Live Symposium here at Mount Sinai. It's always a pleasure and honor to do this and to present these live cases for our audience. I wanted to introduce our moderators today. We have a guest moderator here from Stanford, Dr. John Louie. Thanks for joining us, John. I'm also going to be joined by my partner, colleague, and friend, Jay Vivamurthy, who's here also at Mount Sinai. I want to thank first Broadmed AV for always providing such great AV support for these cases. I guess without further ado, we're going to go over to room 1, where Dr. Marinelli is there, going to present the intro for this case. So thanks, everybody, for joining us. Hey,
All
Brett.
right. Thank you, Aaron. Hey, John, Jay, thanks for joining us. I'm here with our amazing team, anesthesiology, Dr. Popowski. We have Chrissia and Eliu, our nurse and tech, and I'm also here with Tara Ramapour, who's going to introduce our case, yttrium-90 radioembolization for hepatic metastasis. So she'll take it from here and present the case before we get started and show you what we're doing.
So our patient today is a 76-year-old female with past medical history of diabetes, hypertension, hyperlipidemia, and sigmoid colon cancer with hepatic metastasis. She is status post neoadjuvant FOLFOX, followed by low anterior resection and hepatic resection. She had left hepatic lobectomy and segment 8 lesion resection in January of 2025. She received adjuvant FOLFOX and avastatin 12 cycles. Then she had maintenance with 5-FU, leucovorin, and avastatin for better tolerance before being found to have disease progression. She is at this time declining further systemic chemotherapy. As far as her physical exam goes, pretty unremarkable. She is ECOG 0. Her labs are significant for a CAE of 505. So here we have abdomen and pelvis from December of 2025. Shows she's status post left hepatic lobectomy. Segment 8 lesion restriction, and then has multifocal metastatic lesions predominantly in the right posterior sector. So this is from our mapping on March 2nd. The right anterior hepatic artery angiogram and the cone beam CT, where tumor blush is best appreciated on the delayed imaging. This is still from our mapping where we see the replaced right posterior hepatic artery angiogram and the cone beam CT. So this is dominant liver tumor burden, which is appreciated on the cone beam CT. So here we have the MAA SPECT CT. The lung shunt fraction the lung shunting was 4.1%. Here you also see deposition of radiotracer in the gallbladder wall. Then the next imaging was the FDG PET. This was done for yesterday. We did this for as a baseline for assessing future response. And also metabolic response precedes anatomic response. And there were multiple FGG avid hepatic lesions. So as far as treatment planning goes, partition dose modeling was used. The estimated tumor absorbed dose was about 220 gray, and the estimated non-tumor absorbed dose of 73. So assessment and plan, 76-year-old female with sigmoid colon cancer and hepatic met, status post LAR, hepatic resection and chemotherapy, progression of hepatic disease after first-line systemic therapy and wishing to no longer receive chemotherapy. As far as the plan goes, we're going to do Y90 radioembolization of the anterior right hepatic segment using the partition model. The plan after this is to get a PET and repeat the CAE in 1 month to assess the treatment response. And then future intervention is a plan for a second stage Y90 to treat the right posterior segment.
All right, Tara, thank you very much. So we've actually gotten started on this case. We're using transradial access. This is, for all of our patients, or all my patients for Y90. I offer both. I cite some of the literature that we produced on patient preference. And so we elected to go transradial with the mapping. She liked it, tolerated it well. So here we are right now. We've already gotten access to the cystic artery here. And so we're going to drop a fibered and bold coil. And this will just help ensure that the deposition will avoid the gallbladder altogether. There are some reports of cholecystitis with resin, and it being a proximal branch, and we're treating proximally, I really want to get as much of the dose to the tumor within the parenchyma. So Jay and John, any questions about what we're doing today?
Yeah, I was just curious. Do you always coil the cystic artery if it's in the pathway of the Y90?
It's a good question. If there was not such significant uptake on the MAA, I probably wouldn't have. It's not something that I routinely perform.
All right, you can go ahead.
Hey, John, good to see you. Thanks for joining us. I transposed myself over here in the room to give everybody
great.
a hand over here. So, yeah. You were talking about coiling the cystic. This is a big cystic artery. I mean, if it's a tiny one, I think it's totally fine to leave it. But I agree with Brett here. It probably makes sense just to coil it. You probably remember the days where we used to coil everything before Y90, right? Gastric, GDA, cystic, falciform, whatever vessel was in the field. But it's pretty rare that we coil, Y90. It's definitely more common with sear spheres, as you know. But I'm just curious to know, like, what your practice is.
Yeah, to be honest, I haven't coiled the cystic artery, even though I would see it on the Tech MAA. I just generally warn the patient that you're going to have some right upper quadrant pain. We give them discharge meds beforehand, and usually if they do have pain, it lasts maybe 1 or 2, 1 night, 2 nights. But I haven't had anyone require a cholecystectomy because of Y90. But they do show up in the ER if you don't prepare them.
So this is a great example of why coiling some of these arteries can be challenging. This is a 3 millimeter fibered coil, and we elected to use a fibered coil because we wanted this to be as fast of an occlusion as possible. But as you can see, this vessel, even though we measured it at 2.7, if you guys want to focus on the hands here, we can just show you how we're deploying it for people that aren't familiar with Embold. But in general, the fiber coils tend to thrombose better, but these are even at the 3 millimeter size, it can be a little bit hard to push it in. So one of the things that we might do now is to take a soft coil, just to pack it right behind that, just so you guys can see the difference in these different platforms. Do you guys have a soft and Embold soft for us over there? Maybe a 2 even. What do you think? You want to grab a 2, LU? And then once we finish with the cystic, I think we're going to probably be almost ready to deliver the dose. So, John, tell me a little about your practice and your how you're using sear spheres out there in Stanford in California, because as you know, it's different than how we practice here, maybe a little bit.
Yeah, I feel like Y90 is almost like cooking. barbecue. It depends on where the location is. East Coast, West Coast, different institutions. But I mean, for us, we just do it more historically. We do use both resin and glass, probably 50-50 in our practice. And then all HCC is glass, and then all metastatic disease is resin. So we like using both. I mean, you can be one way or another. I mean, I think it's fine as long as you're familiar with the product. How about you guys? Are you guys using resin exclusively, or glass and resin together?
Well, you know, as you know, we do a lot of HCC here. We're very busy with HCC. So for those cases, we're primarily using glass. But as you said, I think for metastatic cases, there's considerable benefit and advantage to using resin. So that's you know, this is a great example of that. We have different, you know, we have so many different options now in terms of dosimetry that it actually, you know, like you said, it's like barbecue, right? There's lots of ways to sort of do this. This is a really interesting coil pack here, right? That was a 2 millimeter soft and bold soft, and you can see how the combination of these two platforms using a fibered and a soft, how different they can be. Yeah, it's really up to, what do you think, Brett? Should we add one more, or are we good?
Let's inject some contrast.
We'll do a little contrast injection.
See how it looks.
Yeah.
You know, I think that you don't need sort of complete occlusion here. This is probably going to be enough to flow redirect as it is, but I think it's good to just demonstrate that.
Brett, any special precautions for the patient that you say specifically related to coiling the cystic?
We'll do one more.
Yeah, we'll do one more. I'll get one more.
Yeah, so just advise her that she could have some abdominal pain afterwards. You know, I think that this, you know, will probably recannulalize later on. So I think the likelihood of cholecystitis is low, but I did let her know that, you know, this is a part of our plan today in addition to the Y90 treatment.
Any utility in just gel foaming this instead of putting in a permanent embolic, or you don't think that's durable enough for flow distribution?
You know, I don't feel as comfortable with gel foam. I would hate to reflux and then, you know, inadvertently cause some distal embolization that would then redirect flow away from some of the tumor burden.
That's a great point. I think gel foam is probably, you know, one of the things about gel foam that I've learned over the years is that it sounds easy, sounds safe, but there's really very few applications, I think, for gel foam in our practice now, when we have, you know, so many better embolic agents. You know, we sort of think of it as a temporary embolic, which is one of its sort of positive attributes, but really it doesn't necessarily mean that it's without complication. And my experience with gel foam is that it's really, it sounds better than it actually is.
Yeah,
that was just a small little 2x4. What were you saying, Jay? I missed that.
Yeah, I've seen situations where it affects your treatment and affects the delivery of your radioembolic when you have gel foam that might, you know, make the flow sluggish in the parent artery. John, you mentioned before something about metastatic disease versus HCC. Is that a historic line in the sand at your institution, or is that?
Yeah, I mean, it's more historic, and then, but you know, just like Aaron was saying, I think there are some benefits for the resin for metastatic disease, because you're treating such a broad area, and you just want coverage, and it depends on the type of metastatic disease, of course, but we've just been mainly historical. Gotcha. Have you guys considered microvascular plugs for, or do you guys use them for like the cystic artery like this?
I mean, we have them and we use them. I just find that sometimes coils are faster and easier. I know the you know, obviously using one plug sometimes is faster, but you know, the size of the plugs doesn't always match the cystic, and so, you know, the coils are just are so effective and so easy, and this is such a good platform for embolization that we tend to prefer coils in this scenario. But yeah, plugs are totally fine. So Brett, what are you thinking in terms of your catheter position here? Where do you want to leave the catheter?
Yeah, so from my experience in the MAA, if you go too proximal here, there is a branch to the GDA here that we can appreciate going medially before this upswinging branch. I do really want to get the branches that we see at the top of this curve. We found from our MAA cone beam CTs that this supplies the caudate where one of the larger tumors is. So there is a balance of trying to get it right. And, based on our MAA, this was the catheter position that we wanted. So from here, what we'll do is a standard 0.5 for, actually we'll increase it. My mind can still be on HCC mode. So I think we're going to go for a 1 for 10 here, DSA, and just wanting to make sure that we have completely forward flow, covering the distribution that we saw in our MAA. All right, so we'll get the power injector ready for a 1 for 10.
John, while they're doing that,
what microcatheters are you, John, what microcatheters you typically use for delivery, just out of curiosity? Everything?
Yeah, if we're doing a lobar dose, like you're doing it in large arteries, then we just use some sort of high flow catheter. So in order to have nice opacification of the target, and also I don't worry about clogging. And then you're pushing with a 20 cc syringe. I don't work out as much maybe as you. You look pretty buff, so I
don't know how you could tell that when we're wearing lead here. I don't know if that's true, John, but that's okay. All right, we're going to do a quick run. We can keep chatting because we're just going to walk out of the room for a sec.
Yeah, I think that's a good point about the high flow catheter. We have a True Select today just because we wanted to be able to get into that cystic artery and proceed with the case. Have you had any experience with a True Select for the Surspheres, John?
Yeah, we've used the True Select. I mean, it's a good catheter. I think I just adjust my microcatheter according to where I'm planning to deliver. So if I'm doing a rad seg, something deep, subsegmental, I'm going to use very small catheters and get out there and be selective. But I just want to be able to see everything, deliver nicely and smoothly if I'm proximal like this.
Yeah, and I think because of the True Select, we'll just take our time making sure that we're mixing the particles well as we deliver. All right, so I think we're in good position here. We're going to now transition towards putting our dose together. We have our radiation safety team here who's going to prepare the room for administration. All right.
John, can you just talk a little bit about your patient selection? Is it mostly just patients that are liver dominant disease and no real extrahepatic disease, or liver dominant with metastatic disease that's just refractory?
I mean, primarily liver dominant disease. I guess I asked the simple question, like, what's the most life-threatening thing for the patient? If it's the liver dominant disease, then we'll treat with Y90, even though there's extrahepatic disease. A small lung nodule is not going to kill anyone. So, or mesenteric nodes. So overwhelming liver disease does. So we just treat those patients. I think the biggest driver for us is like ECOG, their functional status. I think that's a great predictor of how they're going to tolerate the treatment.
And if you're doing whole liver treatments, how are you spacing them out like a month, or how are you spacing out your
Yeah, we're spacing out a month. It is tricky. I think the dosing is the most tricky thing. I mean, how do you guys do the dosing for the partition model?
Yeah,
do you guys
I can touch
use
on that
software
here.
Or?
So, we're currently building our personalized dosimetry program. For those that have done it, it's more than just having the software. It's having a workflow, working with our radiology IT team. So that's something I'm undertaking. And so in the interim, I use the Y90 calculator to do the partition modeling. In this case, an additional component is that because the patient has two arteries to the right liver, we're just going to start with one. It's going to be a staged approach. And that allows us to maybe be a touch more aggressive with this first dose to see how she does, see how things respond. So we calculated the tumor volume, and then taking ROIs of the most FDG avid samples or tumors, we determined our T to N. and then try to titrate that with an acceptable normal tumor dose.
Are you doing
John,
something
is that
similar?
similar to how you? Yeah.
Yeah, I mean, it's similar. I think dosing has just been evolving. I think it's tough. You just basically, I mean, the goal is to get as much radiation to the tumor as possible, and then as little or as the safe amount to the normal liver. And you know, of course, we started with BSA, which is terrible, and then we stopped doing that, and then we moved on to a single compartment MERD model with you know, tumor non-tumor dose. Our target was around 60 gray, and then now we're moving on to using software simplicity and doing a more partition model, looking at the tumor dose and also the non-tumor dose. So it's been evolving. I think for everyone, it's been evolving.
Okay. Do you guys do personalized dosimetry for all of your metastatic cases or cases where you're going to be treating a larger portion of liver?
Yeah, I don't know about you, but the software is kind of a pain in the ass. So I only do it for low bar dosing, metastatic disease. I don't do it for segmentectomies or things like that because it's very straightforward. I think it's tougher when you're treating a whole liver or both lobes. I kind of want a margin of safety.
Yeah, that's been the experience that speaking to a lot of other folks and for us as well. You know, you don't need anything fancy for the MERD dosing. It's very straightforward. You know, it's something you can just calculate on your post-processing software in the control room. It takes about 2 minutes afterwards.
Can you guys focus in on the box here, if that's okay? Let me know when you can see the box go over there on your end, John and Jay.
We can see it.
Yeah.
Okay.
If we zoom in a little bit, it
So
might be...
this is, you want to zoom in? Okay, so this is the relatively new Sphere Ceros box, much easier to deliver the dose. The first thing we're going to do is we're going to just clip everything together here. So we're going to put C line here. Just get that in there. We're going to put the B line into the B line. It's all marked for you, so it's very easy to set up. C is going to go over here, and then D is going to go here. So on the B line, we're going to put some contrast. So the first thing I'm going to do is I'm just going to flush this line with contrast. Actually, I'm sorry. I'm going to use D5 for this. So just so we don't have contrast in the line. So I'm going to flush this with D5, clear everything out. That looks good. Then I'm going to take the D5 and I'm going to put this through the D line. And we're going to clear this line. We're going to knock the bubbles out like we do with all the other Y90 kits that we use. Sometimes pulsing it helps. We'll do another flush on the. Okay, let's get all the little bubbles out. Yeah, so let's do that. Try to get all the bubbles out. This is the most important thing. We don't want bubbles interrupting our delivery, obviously.
So that dual injection really helps clear out the bubbles.
Okay, so now Brett's going to hook up the catheter to the box. We want to make sure the table's a little lower. So for those that don't use this, you just want to make sure that you have a downstream flow.
And we have our towel bridge here in addition, and I always spot check one last time to make sure that catheter position hasn't moved.
So now I'm going to hook up a contrast line to the B line. I'm going to let that sit there. Now I'm going to put this together. So I'm going to take, let's see, here's the D. We're going to unscrew this over here. D is going to go to D. Nice and tight.
Guys, what day pre-calcs are you guys using?
So this is day of calibration. So we're trying to maximize the number of particles. It is a fairly large perfused volume. And so to that point, we will need to check with contrast as we deliver to make sure that we're maintaining antegrade flow.
So we can fluoro now before we inject. We're going to just make sure that we're in the same position. We can even zoom in a little bit just to make sure everybody can see what we're doing. Okay, let's take a look at that. Good. Good. So we can do a little contrast injection, and it's good to use 20 cc syringes, obviously, because it helps control the flow. As we get through this catheter here, we're going to start to see the contrast. There, you guys can see it now. Okay, so now we're ready to start injecting. So if you look at the vial here, I like to agitate a little bit as I inject. So I just sort of pulse it. And once it comes out into the A line, right there, that's going to be the highest concentration of spheres.
So we probably only want to do a couple of cc's at a time because that is the highest number of spheres. You know, this is the point at which it's maybe most prone to clumping.
And even reflux too, right? So now I'm going to switch to the B line. I'm going to try to pulse in with a little bit of contrast so we can see what we're doing. Now, obviously, when we see the contrast, that's generally after the spheres have been delivered. So that's how we know that first aliquot went in. And we're just going to go back and forth between the B line and the D line. One of the things about radial axis is you have a bigger dead space in your catheter, so it just takes a little bit longer to see the contrast. And you can see it there. So that's the first aliquot. It's definitely going in, and we're going to go back and forth. Nice and smooth, easy to inject. This is a good sized dose. We got 62 millicuries here, so 2.32 GBq. Just taking a look here.
And we can appreciate the resin moving through as we look over the first lighted area.
You were going to say something,
Will you
John?
do a post PET CT, post wet Y90 PET CT, or no?
So that's not something we routinely do. We have done in the setting of a research trial. We do just the standard SPECT after this.
Nice.
How about at Stanford? Do you all routinely obtain PETs or just specs for many of your Y90 cases?
Yeah, I think for the last several years we've been getting post Y90 PET CTs, but you know, of course, they don't reimburse. So we have an arrangement with the nuclear medicine department, so we kind of do it free of charge.
Yeah, I think that you just pointed out one of the pressures on, you know, being able to do this routinely is that you know, FDG PET just reimburses so well and is the workhorse for the nuclear medicine departments.
So, you know, there's not really a rule in terms of how many aliquots to do, but when you're in a proximal vessel here, I like to just go aliquot back and forth. I mean, you could push, if you wanted to, you could push more in each aliquot, but you know, I tend to go more after most of the vial is in. And you can see we've injected a considerable amount of this dose already. Okay, we can fluoro just to see.
All right, so we're gonna.
But you take your time. You can see there's a little, you know, we definitely got a lot in there. You can see that there's some stasis even already, a little bit. So we're gonna just go slow.
I agree.
How many spheres do we have
this
here?
This part is to just take your time. There's no rush.
23 million.
23.
Yep.
Yeah.
And you can see there's like a couple of beats now that we're appreciating with the contrast as it goes in.
We can stop whenever we want, but we're not gonna. We're gonna keep going.
So we still have a lot of syringe here.
You can actually take a look under fluoro, just because I think that the contrast should be cleared.
Contrast is cleared.
Now I'm injecting spheres.
Okay.
John, what's your process from going from mapping to treatment? Is it a week out, or I'm trying to do them same week? How are you managing that?
I think everyone wants to do it faster. I've tried the 1 day. I don't know. New York probably they want everything now, but or yesterday. But I feel like that hurts me, so I try not to hurt myself. So I don't do same day. I'll do back to back or a week later, depending on where the patient is and coming from and my schedule. So I'll try to make it, within a week. How about you guys?
Yeah, I'd say right now it's probably about 9 days, 10 days. I find, similar to you, it's nice to have that time, especially if you're doing partition modeling or personalized dosimetry, to just take your time, being able to do those calculations and not feel like you have to rush and turn it around.
How are you
John, so when
following?
do you stop injecting? How do you decide when you're done?
It's when it's clear. About,
Yep.
I think,
So
20 to 30 cc's.
So you can look here. This was a full 20.
Mm-hmm.
So we're actually about halfway done with the 20. So if you guys can focus in on the box, it looks relatively clear, but there's still a few spheres left in there. And this is all just D5 going in now with the spheres. So we could do another aliquot, or we could just flush the rest in. Why don't we do one more?
Mm-hmm.
Sorry, I didn't mean to interrupt you. What were you saying, John?
John, how are you?
No, I was just curious how the spacing. We were just talking about between part 1 and part 2, and how you guys do it.
The first, if we're dosing like 2 areas of the liver, you mean, or the MAA and then the Y90?
The MAA and the Y90. I mean, do you guys ever skip the first mapping
It's a great question.
for like segmentectomy?
So I think it's something that can be done, especially if you're very distal. And there have been studies that have looked at a large number of patients where the lung shunt fraction is negligible, and certainly when you're getting distal enough, the risk of extrahepatic deposition is almost nothing. But it hasn't reached our routine use.
Yeah, those are special cases for us.
I think we're done.
Usually HCC less than 5 centimeters. We'll just skip it, all order doses, and then deliver.
All right. So it looks like we're basically done here. It's pretty clear. So we're going to take the catheter out now. I'm going to grab our little bucket here. This over here, take these off.
And so, John, that must have made a lot of the workflow much easier, not having to do those MAs. What percentage of your practice are those less than 5 centimeter HCCs where you're now foregoing the MA?
I would say not that common. I mean, less than 5. That's very uncommon to have solitary less than 5 centimeter tumors. So I'd say just a handful.
Got it.
John, are you guys doing radial access a lot out there in California?
I have to say, I'm more like with Ed Kim. I'm more of a femoralist.
Yeah.
So radial's nice, except I can't get it to work on our machines as well because of the cone beam.
Oh, so what machines are you guys using out there typically?
We have Siemens, so it's fixed on this. It's a 200-degree spin, so it makes it very difficult. I'll clip off an arm if I do that.
Well, there are different ways to do it. We can, you know, we're not going to do a cone beam today, but it would be really cool to show. We've done that in the past. We've shown different ways that we've done cone beams on Siemens and Philips that really help with the radial access. And so the open trajectory has been, you know, really the best way to do it. We're just going to scan our gloves and close this up. But yeah, I as you know, we like radial access just in general because it's easier for the patients to recover and get out of here. And I think for, you know, for somebody that's getting this type of treatment, it makes a lot of sense to get out of here faster. All right, so that's it. That's the dose. We're going to take this catheter out and we're going to put a TR band on the wrist. Do we have a TR band real quick? Any last comments, questions from you guys?
Yeah, how are we going to assess whether this worked? How are we going to space out the imaging?
Yeah, so we're actually going to get a PET scan in 1 month. And based on what we see, what the response is, how she's tolerated the therapy, we're going to plan for the second stage. We'll also get standard labs, CBC, CMP, CEA, to make sure that, she hasn't had any adverse events and is also fit for a second treatment.
Do you always see a response at the 1 month?
Not always necessarily, but that's why we get the PET scan, because usually if you do see a response, metabolic can precede the anatomic recyst response with colorectal.
If you guys want to focus on the wrist, we can just show the TR band real quick.
John, have you ever used circulating tumor cells to see if there's response after local regional therapy?
We haven't, but that's something that's actually been more, for us, been more monitoring. So if they have a great response, and sometimes the hepatologist will do a cDNA and actually have a prompt sooner imaging or treatment depending upon what the cDNA shows.
That's gonna be really
So
cool to see
can you guys see the wrist here real quick?
Yep.
Yeah, looks great.
Yeah. So one of the things that just happened now is when I pulled the drape off, I actually pulled the sheath out. And so when that happens, what you should do is hold a little pressure there and then put the TR band on right above the access site. So not the skin entry site, which is sort of the important thing, but actually slightly above the skin entry site, because that's where you enter the vessel. So one of the mistakes that people make with this device is they actually put the green dot over the actual skin entry site. And so there are some situations where when you do that, you can actually bleed above it or below it. And so that's really the teaching point there. But in general, we put about 15 cc's of air and then we decrease it to about 10, and that's generally where we get patent hemostasis. And as you can see, we have that now. Any last comments from the moderators?
No, it looks great.
Thanks for waking
up. All right.
up
Well,
early.
thanks for joining us, guys. Yeah. Thank you, John, for getting up early. I know it's early out there, but we appreciate your insights. And thank you, everybody, for tuning in. We're really happy to be able to present these cases for everybody for educational purposes. And so thank you. See you next month.
Thanks, everyone.
You.
Thanks,
Have
Eric.
a good one.